Mitch here from Vet Triage. This will be published on February 2nd, 2025. We are going through this issue of veterinary surgery. This is from April 2022. And we're going to talk about submucosal resection via a transanal approach for treatment of epithelial rectal tumors, a multicenter study. This study comes out of a specialty center in the United Kingdom, another specialty center in the United Kingdom, a third in the United Kingdom, a fourth in the United Kingdom. Then we've got the university in Italy, and then we have another university in Italy, a third university in Italy, and then Royal Veterinary College in the United Kingdom and University of Liverpool in the United Kingdom. The picture you see there is an example of how you can remove a rectal tumor. There are many, many different surgeries to do this, and we'll go over them right now. The objective is to report complications and long-term outcomes after submucosal resections of benign and malignant epithelial masses of the rectum. Retrospective study, 93 dogs. Results, duration of follow-up, 708 days, 29% complications, 21% recurrence, with 12 out of 20 dogs with recurrent masses treated with repeated submucosal resection. Median survival was not reached in any group. The 1 year, 2 year, and 5 year survival rate for carcinomas were 95%, 89%, and 73% respectively. Overall survival was longer for benign tumors and carcinomas. Recurrence was more likely when complications or incomplete margins were present. Recurrence was associated with increased chance of death. All right, introduction. Rectal tumors account for less than 10% of all dog tumors. More than half of colorectal masses are malignant. Adenocarcinoma is the most common. Multiple surgical techniques have been described. Transanal rectal eversion and submucosal resection. Dorsal inverted U approach, caudal abdominal approach combined with a pubic symphysiotomy or bilateral pubic and ischial osteotomy. Rectal pull-through procedure. Transanal pull-through procedure, and Swenson's pull-through with modifications. Some of these surgical techniques are invasive with complication rates as high as 100%. So all that list of surgeries you want to know if you're studying for your surgery boards. A recent article on transanal rectal pull-through report a median survival of 696 days and 1,006 days for removal of rectal carcinomas and carcinomas in situ, respectively, but multiple complications occurred, as well as severe perioperative mortality. Human rectal masses is much more refined with different treatment options based on location, so high rectal versus low rectal, and the stage, early versus advanced. Preoperative staging with MRI and endoscopic rectal ultrasound are critical to determine whether a multimodal or surgical first approach is indicated. Materials and methods, study design, 2006 to 2019. Medical record reviewed, post-op complications were defined as transient if they resolved, permanent if they persisted until death or a last follow-up. Complications were classified as minor if they resolved spontaneously or required medical therapy, major if they required surgery. Regarding surgical technique, the dogs were placed in sternal recumbency, tail reflected cranially, rectal wall was everted through the anus, marginal elliptical incision of the mucosa and submucosa performed around the mass, 10 millimeter lateral margins using sharp and blunt dissection, apposition of mucosa and submucosa in one layer, simple interrupted or simple continuous with absorbable monofilament suture. Statistical analysis. For survival analysis, dogs are grouped into three categories based on histopath of the rectal mass, either benign rectal epithelial mass, so adenomas and hyperplasia, carcinoma in situ, and rectal carcinoma. Rectal masses were classified as carcinoma in situ if they contained marked cell dysplasia, but they remained confined by the basement membrane and did not show an invasive phenotype. All right, results. Male to female ratio, 1.44 to 1, meaning males are more predisposed. Mostly spayed females, and a very close second are castrated males. Mean age was 93 months. Which I hate when they do that, just convert it to years, but that's 7.7 years. Median body weight, 20 kilograms. And the most common breed was mixed breed, followed by West Highland White Terrier, and then third was Labrador Retriever. Pre-surgical clinical findings. The most common clinical sign, hematochezia at 88.2%, followed by tenesmus 33.3%, and dyschinesia 12.9%. Median duration of clinical signs was 8 weeks. Rectal abnormalities were detected on rectal digital palpation in 95.7% of dogs, with a palpable mass in 94.6%, and an abnormal or irregular rectal wall in 1.1%. Median and maximum tumor diameter was 1.9 centimeters. Median distance of the tumor from the anocutaneous junction was 2 centimeters. No metastatic lesions identified on radiographs. Abdominal ultrasound in some dogs showed lymphadenopathy of the mesenteric lymph nodes and other lymph nodes. Abdominal and thoracic CT scan did not show any metastasis other than maybe mild lymphadenopathy in some dogs. Endoscopy identified rectal mass in all of the dogs, followed by also edema and erythema and other abnormalities. Cytology was also performed in some of the dogs, and preoperative fine needle aspirates of the rectal mass was consistent with the post-op histopathology in only 2 out of 5 of the dogs. Rectal carcinoma in both cases. Pre-surgical biopsies performed in 45.2% of dogs, with results being consistent with the diagnosis in only 64.3%. Overall, the examination of the whole surgical sample was suggestive of a more aggressive pathology in the majority of cases, 69%, where a discrepancy between pre-surgical and post-operative samples were present. All right, surgical results and complications. Median surgery time, 25 minutes. Median hospitalization time, 1 day. No intraop complications. 29% had at least one complication after surgery. Mostly were minor at 96.3%. Major was only 3.7%. Transient complications, 96.3%. And then complications were transient in 96.3% of dogs, with complications 27.9% of dogs in total. Dyschinesia was the most common complication, which is 14% of dogs, transient in 12 of the dogs, permanent in 1 dog. Median duration of dyschinesia was 24.5 days. Tenesmus was observed in 12.9% of dogs. Median duration of tenesmus was 14 days. The only major complication consisted of wound dehiscence, 1.1% of dogs, which prompted revision surgery 5 days after the first surgery. Regarding histopathologic diagnosis, the most common one was rectal adenoma at 47.3%, followed by rectal carcinoma in situ, which is 24.7%, followed by rectal carcinoma, 22.6%, and then rectal hyperplasia, 5.4%. Excision was complete in 73.3% of dogs. Follow-up and post-operative outcome. Median follow-up was 708 days. Tumor recurrence, 21.5% of dogs, 20% with rectal hyperplasia, 13.6% with rectal adenoma, 30.4% with carcinoma in situ, and 28.6% with carcinoma. Margins were incomplete in 40% of recurrent tumors, whereas 45% recurred despite complete excision. 60% of dogs with recurrence had repeated submucosal resection via a transanal approach. Overall reoperation rate for benign tumors, meaning hyperplasia and adenomas, was 42.9%. Of the 21 dogs with rectal carcinomas, 4.8% was diagnosed with preoperative metastatic disease, and 4.8% developed metastasis later on. At the end of the surgery period, 89.2% were either alive or cause of death was unrelated to the rectal disease. The median disease-free survival and overall survival for dogs for rectal epithelial neoplasia was not reached. The 1, 2, and 5 year disease-free survival rates were 94%, 89%, 85% for benign, 87%, 70%, 64% for carcinoma in situ, and 75%, 75%, 75% for carcinomas. The 1 and 2 and 5 year overall survival rates were 100%, 97.5%, and 97.5% for benign tumors, 100, 180% for carcinoma in situ, 95, 89, 73% for rectal carcinomas. There was no difference in disease-free survival when comparing benign with carcinoma in situ, benign versus carcinoma, or carcinoma in situ versus carcinomas. There was also no difference with overall survival when comparing benign tumors with carcinoma in situ or carcinoma in situ versus carcinomas, but there was an overall survival that was longer for benign tumors than carcinomas. Risk factors that were associated with recurrence and survival. The only factors associated with increased risk of recurrence include having a complication or incomplete margins. The only factor associated with increased risk of death was recurrence. All right, discussion. The complication rate in this study was 29%, lower in previously reported for transanal submucosal resection. In another study, 43% of dogs developed minor complications like tenesmus, hematochezia, and partial dehiscence, which were managed conservatively. More aggressive surgical techniques, which have been reported complication rates as high as 100%, with up to 33% experiencing permanent complications of fecal incontinence, and others. The severity of these complications can result in death or euthanasia. It is intuitive that submucosal resection via a transanal approach is not suitable for annular or deeply infiltrated masses. Recurrence rate in this study was 21%, which is far from negligible. Recurrence rate was higher for rectal carcinoma at 28.6% and for carcinoma in situ at 30.4%. However, repeat resection was possible in the majority of cases, and only about 10% of dogs died of tumor-related causes. Another study reported a recurrence rate of 13.7% with partial or complete rectal pull-through, despite more than half being malignant. Nonetheless, morbidity was also higher, with 9.5% of dogs dying or being euthanized as a result of a complication. Repeat submucosal resection was indeed performed in 60% of dogs with recurrence in this study, was well tolerated and prolonged the disease-free survival as well as the overall survival. Another option to consider a submucosal resection via a transanal approach as the initial approach and reserve rectal pull-through, or alternative approaches for full-thickness resection in case of incomplete excision or to address recurrent malignant tumors. In people with early-stage rectal cancer treated with local transanal excision, salvage radical surgery for a recurrence identified is associated with higher recurrence risk and poor oncological outcomes. Instead, immediate salvage radical surgery after incomplete resection within 30 days of local excision provides oncologic outcomes comparable to matched patients going directly through radical surgery. As a consequence, and based on these results, it is currently not possible to preoperatively identify the subset of patients that may benefit from more aggressive procedures. In human literature, local excision can be achieved via transanal open or endoscopic procedures such as transanal endoscopic microsurgery and transanal minimally invasive surgery, as well as via endoscopic submucosal dissection. Meticulous preoperative staging with MRI and endoscopic rectal ultrasound are critical for staging human patients with rectal cancer to assess the depth of rectal wall invasion and to channel patients into the most appropriate treatment pathway. Advanced imaging is used to classify tumors according to clinical T and N classification, which ultimately are only information available for decision making before surgery. Clinical T, based on MRI, and endoscopic rectal ultrasound has been proven to correlate well with the pathological T, the T classification based on histopathology of the resected mass, all allowing clinicians to identify early stage cancer before surgery. Transanal approaches are considered for early stage low rectal cancer. However, even in the subset of patients with T1 or T2 and 0 low rectal tumors, radical surgery remains a good option with excellent oncological and functional outcomes with sphincter preservation possible. Transanal options play a crucial role when location near the sphincter requires perineal resection and permanent colostomy with the associated high morbidity. Transanal surgery with local full-thickness excision is considered for endoscopic rectal ultrasound, stage T, IS, and T1 lesions that do not have negative prognostic factors, meaning poorly differentiated histology, lymphovascular or perineural invasion, more than 30% wall involvement, and a size greater than 3 centimeters. It could be speculated that canine rectal tumors may be biologically less aggressive than the human counterparts. Annular or deeply infiltrative masses. In this situation, decision-making for the veterinary surgeon is simpler, and options include a pull-through procedure, a colorectal resection, and anastomosis via pubic symphyosotomy or bilateral pubic and ischial osteotomy or palliative colorectal stenting. All this you need to know for your surgery boards. West Highland white terriers appear to be overrepresented, which is consistent with other studies. Male to female ratio in this study 1.44 to 1. Previous studies show that males are overrepresented with ratios of 3 to 3.7 to 1. Sampling of the massive force surgery was often unreliable, with only 64.3% of pre-surgical biopsies consistent with the final histologic result. Nonetheless, pre-surgical sampling may remain useful, particularly if addressing large masses that are not amenable to surgery and may respond to medical therapy such as lymphomas and plasmacytomas. Rectal carcinoma in situ, grouped separately due to some controversy on their classification. They are generally classified as benign, despite the fact they show marked cell dysplasia. They're not benign. They're not benign. It's dumb. A previous study suggests that rectal carcinoma in situ may have a worse biological behavior than rectal adenomas. In this study, rectal carcinoma in situ did display an intermediate behavior between benign and malignant, which makes sense. The median maximum tumor diameter in this study was 1.9 centimeters compared to 2.5 centimeters in another study. So my only criticism of this paper really is you want more animals, which is always the case. Get a larger sample size. Otherwise, pretty solid. Yeah. I do wish they showed some pictures, like drawings of the surgery as well, so we can have a better idea of what they're thinking. But otherwise, solid paper. And we'll see you guys again tomorrow. Take care.